La Junta Directiva de la Asociación Colombiana de Ginecólogos Oncólogos tiene programada una conferencia con un tema muy especial. ¿Por qué no estamos enfrentando los problemas sexuales de las sobrevivientes, de las mujeres sobrevivientes de cáncer? Es un tema que los ginecólogos y los médicos que en general tratamos pacientes con cáncer pocas veces tratamos con nuestras pacientes. ¿Cuándo debería ser un tema prioritario? En cualquier momento de la consulta, antes del tratamiento, durante el tratamiento y después del tratamiento. Y la conferencista de hoy es la doctora Laila Agrawal, que es una oncóloga clínica que ha tratado este tema y le gusta mucho, le apasiona y nos encanta tenerla hoy acá. Doctora, doctor, we are very pleased and very honored to have you here. Y la doctora Heidi Ramírez será la moderadora. Recuerden que pueden hacer sus preguntas por el chat o levantar la mano, apagar sus cámaras y recuerden que esto va a quedar grabado en nuestro canal de YouTube. Heidi, tienes la palabra.
Muy buenas noches para todos, doctora Lucrecia, muchas gracias. It's a pleasure for me to introduce you, Dr. Laila Agrawal. Para mí es un placer presentarles a ustedes a la doctora Laila Agrawal. Ella es, como lo comentó la doctora Lucrecia, hematóloga oncóloga, quien labora actualmente en el Instituto de Cáncer de Norton, en la ciudad de Louisville, en Kentucky. Y se dedica básicamente a los temas de cáncer de mama y salud sexual. Están todos invitados a hacer sus preguntas durante la charla a través del chat o al finalizar la charla. Recuerden el tema que les acabo de explicar la doctora de la posibilidad de escuchar la charla en inglés o en español. En la parte inferior de la pantalla de Zoom está la opción de interpretación o idiomas para que ustedes cambien el idioma a su preferencia. Dr. Laila, the audience is yours. Thank you for being with us.
Thank you so much for the introduction. I'm so happy to be here. I'm just going to share my screen. Here we go. Okay. Can you see my screen? Very good.
Yes.
Yes.
Okay, wonderful. So I'm a medical oncologist, as Dr. Mira said, and I specialize in breast cancer. And through my work as an oncologist from my patients, I saw so many women had problems with their sexual health, and those problems were not being addressed. And so that led me to develop a sexual health program at my hospital, where I now see and treat women who have sexual concerns or sexual problems that develop after being diagnosed with cancer and going through the cancer treatment. So here are my disclosures. So talking about sex and cancer, why is it important? So I think it's important to understand that sexual health is fundamental to the overall health and well-being of not only individuals, but also couples and families. And it is relevant not only when women are of childbearing age, but throughout an individual's lifespan, including patients that are older, patients that are younger, those who have partners, those who don't have partners. And so it's really important to address sexual concerns for all of these patients. So cancer and cancer treatment, as we all know, can negatively impact sexual health for women. And it can do so in many different ways. So surgery, for example, many types of gynecological surgery can have impact on a woman's sexual function, including surgeries that induce premature menopause. Chemotherapy can also cause premature menopause and other side effects, as can radiation, hormone blockers, and even stem cell transplant. So when I'm looking at sexual health for a woman after diagnosis of cancer, I look at it through a model that is called a biopsychosocial model. And what that means is there are biological factors, psychological factors, and social and interpersonal factors that all play a role in sexual health. And when women are diagnosed with cancer, all three of those areas are impacted, and all of them can impact sexual function. So when it comes to biological changes, there are hormonal changes, anatomical changes, which can include vaginal atrophy, as well as vaginal stenosis. Many types of cancer leave women with a loss of a body part, and often a body part that is related to sexuality. So for example, a breast when it comes to breast cancer, or female gynecological organs. And then sensation is changed too. Breast sensation, nipple sensation, clitoral sensation, other things like that are different, and patients can experience pain and fatigue. In the psychological area, there are many impacts to mental health, including emotional changes like depression, anxiety, changes in body image, thought patterns. And when it comes to social and interpersonal changes, there can be changes within the two partners in a relationship. Concerns can develop there. Communication becomes even more important. There can be changes to the way a couple communicates and has intimacy. And then religious beliefs, cultural values, as well as social norms play a role there as well. So sexual problems in women after cancer is very common. So long-term sexual problems have been reported in 50% of breast cancer patients. Some studies show even much higher than that. Estimates for patients with gynecological cancers are 65 to 90% of gynecological cancer patients will have long-term sexual health problems. So that means that the majority of patients that you might be seeing in your practice may be experiencing these sexual problems. And so it's important to address this for all patients. Colorectal cancer patients also experience sexual health problems. And then looking at one specific problem, which is pain with sex, it is extremely prevalent. 45% of breast cancer survivors may have pain with sex, and 55% of patients with a gynecological cancer or a rectal cancer may have pain with sex. So these are really important symptoms that are impacting patients. There also can be a difference in the way that sexual health is addressed for female patients and for male patients. So this particular study was done in the US, and it was done in a radiation oncology waiting room where they did a survey and asked patients about their sexual concerns and if their medical providers had ever asked them about it. And in this study, 87% said that cancer treatment had impacted sexual function or desire. 73% reported pain, 53% reported body image changes, 42% were unable to have an orgasm. And out of all of those patients, only 27 had actually been asked by a medical professional if they had any problems with sexual health. So this shows a huge gap between what our patients are experiencing and what we as medical professionals are asking them about and offering them. And looking a little further in this particular study, there was a gap or a disparity between women and men in the study because female patients were less likely to be asked about sexual health than male patients. And that was statistically significant. Sexual dysfunction can certainly impact patients in many different ways. One study through the Live Strong organization ranks sexual health as the third most common concern among cancer survivors. And it has been shown to be associated with distress, poor quality of life, and mood disorders, and certainly has a major impact on patients' quality of life. So why are these conversations not happening in the clinic? What are the barriers? So there have been multiple studies that have looked at the barriers to addressing sexual health, both on the side of the patients and the medical professionals. And what it comes down to for patients is some concern about making the doctor feel uncomfortable, some embarrassment, and also a belief that if sexual health is an important medical issue, the doctor will be the one to raise that question. And if it hasn't been raised by the doctor, that sends the message to the patient that it's not important medically. Many patients also may feel that sexual health concerns are not valid or are not treatable. And I hear this a lot from patients, saying that they felt that they should just be grateful that they were alive and shouldn't care about sexual health. And that's just not the case. On the part of medical professionals, there's certainly a strong feeling of being insufficiently trained or skilled to address this. And I think that's very true because the majority of traditional medical training does not address sexual health adequately. And professionals may feel discomfort about bringing this up with patients, as well as not having time and being concerned that the conversation will take a very long time and not having the time to do that. In fact, that's actually not the case. Many times these conversations can happen quickly and they can be addressed with actionable items in a really timely way. There's also concern of making the patients feel uncomfortable, but multiple studies have shown that patients want to be asked these questions and they want their providers to be the one to raise the conversation. And then certainly some assumptions come in to play, such as if a patient is older, they don't care about sexual health, which is not true. If a patient doesn't have a partner, it's not important, which is also not true. And then certain resources or specialty services for sexual health may not be available. So in the coming hour, I'm going to talk about how we can overcome many of these barriers and how we can ask patients and deliver these services even within our own clinics. So in terms of education and information about sexual health, now multiple organizations have come out with guidelines of how to address these concerns. And so ASCO has come up with a guideline that addresses interventions for sexual problems in people with cancer. And this really outlines very nicely the types of concerns that are common and the appropriate treatments and interventions for these concerns. So I'll be referencing this particular guideline a few times throughout this conversation. So the first recommendation here is that there should be a discussion with the patient initiated by a member of the healthcare team regarding sexual health and sexual dysfunction. And so that's really the key thing. Everything that is following today cannot be used unless somebody on the medical team has taken the initiative to ask the patient. And so how do we do that? How does one assess sexual health in the clinic? So there's a really nice paper that outlines exactly how to assess sexual health, simple things that can be done by medical professionals in the clinic. And what I'm hoping to do today is to give you many different tools of how you could approach asking patients about sexual health in the clinic. So this model starts with screening patients for sexual health concerns, and then a simple 4-step model, which gets essentially to what is the story, what is the concern, and then doing what's called a core level assessment, assessing sexual response, sexual pain, and relationships, and then the distress that those issues cause to the patient. And then the core level treatment is basic treatment, which can be recommended by medical professionals. And at any point in that process, you can refer out to a more advanced level or to specialty services when appropriate. So how to screen for sexual dysfunction. So here I'm going to go over several methods that are included in that model and then a few others that have been published separately as well. And what I would encourage you to do as I go through this is to think about which one of these methods would fit nicely into your practice and how you interact with your patients. And then maybe sort of a challenge to, in the coming week, try these out and see which one feels comfortable, which one do your patients respond well to, and what fits into your flow of the clinic. So the first method is just ask. So as simple as it sounds, you just ask the question. So for me, as a breast medical oncologist, I'll often ask my patients, do you have any concerns about sexual health, such as interest in sex or libido, vaginal dryness, or pain with sex? So this is just a question assessing their sexual function. Another simple question would be, have you experienced any changes in sexual health or in urinary health? And sometimes adding that it's sexual and urinary health is a way to kind of normalize this as a medical issue and a medical concern. Another really helpful tool that I use a lot, especially when I'm first discussing sexual health with a patient, is a ubiquity statement. So this is a statement that normalizes and universalizes sexual concerns. So to start the conversation, you're not asking the patient anything specific about herself, just making a general statement. So for example, many patients with breast cancer have changes in their sexual health. So that just establishes sexual health problems can be the result of breast cancer treatment. It's very common. It's a very sort of normal symptom to experience, but it is treatable. And then follow that up with specific questions like, do you have any concerns? Do you experience vaginal dryness? Have you experienced pain with sex? Have you had changes in your libido or desire to have sex that are distressing to you? So, thinking of a normalizing or a ubiquity statement is a way to start this conversation. That's very helpful. Another way to ask is in the context of a patient's relationship. And this might make most sense when you're meeting with a new patient. Are you in a relationship? Are you sexually active? Do you have any concerns about that? So that's a very natural time to introduce sexual health as a medical issue that can be discussed in the clinic. And so if it's mentioned by the medical professional or the doctor in the first visit, even if it's not a deep discussion, it's laid the groundwork that this is something we can talk about. So then in the future, the patient knows this doctor is not embarrassed to talk about this. This doctor is comfortable talking about these issues. They've already asked me if I have any concerns. So if anything happens later, I can go to them with those concerns. So if a model for screening sexual function is to first legitimize the importance of assessing the sexual function. And simply by asking the question, you are doing that. So for example, are you currently involved in a sexual relationship? If the answer is yes, you can ask, do you have any concerns about sexual health or any pain with sex? And if the patient answers no, and this is really important, that's not the end of the conversation, because you need to ask, or you need to know, is there a reason that they're not having a sexual relationship? Is it because of pain? Is there a problem or a medical concern that is leading to the lack of sexual activity? And so after they answer no, the follow-up question would be, do you have any sexual concerns that you'd like to discuss, or anything that's contributed to that? And so just to summarize, screening for sexual dysfunction, it's important to normalize or universalize the conversation about sexual health. Start with the ubiquity statement and then follow up with some open-ended questions. And then I think it's really important to ask specific follow-up questions. The patient may not know what you mean by sexual health. And so specific questions like, are you having pain? Are you having dryness? Are you having decreased lubrication? Do you have irritation? So that the patient knows what are the concerns that maybe could be treatable or that might be bothering them. Then this next model is called the Plicit model, and this has been around for a long time, since the 1970s. And it's still a really nice model for assessing sexual function and taking it step by step and leading the patients to the appropriate therapy. So it starts off by first having the medical professional lay the groundwork and give permission to discuss sexual health. And they do so by just by asking about these sexual concerns, and then to provide a limited amount of information. So it doesn't have to be a very long conversation or a long assessment, but to just give a small piece of information, and followed by specific actionable suggestions. And then if those don't work, the invitation for the patient to let you know so that they can be referred for more intensive therapies. So how would this look? So here's an example in the cancer clinic. The statement to give permission to discuss would be something like the ubiquity statement. Sexual concerns are common among patients who have had breast cancer. Are you having any concerns? And then limited information. For example, aromatase inhibitors, a commonly used medication for breast cancer, can frequently cause vaginal dryness. So sometimes a patient might experience the symptom and not know if they haven't been told that it's the result of the cancer treatment. And then a specific suggestion, for example, would be using vaginal moisturizers and lubricants can help. And then the invitation for the intensive therapy, if that doesn't help, let me know. And there's other options that we can refer you for. And so that tells the patient that's not the end of the treatment options. There can be more if that doesn't work. And so I think this is actually really quick, really easy to do in the clinic, and can be done in a really timely way as well. And then finally, another screening tool, which can be very helpful, is this checklist that was published by Sharon Bober and colleagues in a really nice article about addressing sexual health. And this checklist that I have on the screen here can actually be printed out from the article, and cards can be made, for the clinic. So a patient could have a stack of cards in the exam room while they're waiting for the doctor to come in and be asked to fill out this checklist. And so the first question is, are you satisfied with your sexual function? Yes or no? And the second question is, do you have any concerns about vaginal health? And so that's really important, because even if a woman is not sexually active, it might be because she has concerns about her sexual health, or she may not wish to be sexually active, but still is having problems related to sexual dysfunction, such as dryness, pain, genitourinary syndrome of menopause, or others. And then if the patient answers yes, it directs them to go on and discuss these specific concerns, such as little or no interest in sex, decreased sensation, decreased vaginal lubrication or dryness, difficulty reaching orgasm, pain during sex, vaginal or vulvar pain not associated with sex, anxiety about sex, or other. And so this could be a helpful screening tool that the nurse or the medical assistant could direct the patient to complete. And then you would know right away whether there's something that they want to talk about or not. So this is another option for how to incorporate assessing sexual health for all the patients. So to summarize, these different methods are the just ask method. So just incorporating the question as a straight and simple question. Are you having any concerns? Just like we ask about so many other things, nausea, pain, infection, fever, just put sexual health on that list as well. To remember the importance of the ubiquity statement in introducing this topic, just a very broad statement saying that sexual health concerns are common after this surgery. Have you experienced this? Asking in the context of the patient's relationship, especially with a new patient, that normalizes the conversation about sexual health from the beginning, and it establishes that that's something that the medical provider is comfortable discussing, and that sexual health is a medical issue that is valid too. The basic assessment of sexual function, asking patients if they're sexually active. If yes, are there any concerns? If no, are there any reasons why they're not? And then remembering the implicit model, just to set the permission, to give limited information, specific suggestions, and then refer for intensive treatment, and then to utilize the checklist. So personally, I use several of these different methods daily, just depending on how things are flowing with my patients. I use the just ask method all the time. I use the ubiquity statement very much so. I make sure to ask the follow-up question, and that is really where I have found a lot of really important information. So, I may ask, do you have any concerns with sexual health? And the patient might say no. And then ask the follow-up, do you have any dryness or any discomfort? And they might say something like, oh yeah, it burns like razor blades. I haven't been able to have sex for 4 years since my cancer diagnosis. So that follow-up question really can, open up the heart of the matter for the patient. So now moving on to what do you do after you've opened that conversation? So the next step is to get a little more information to sort of frame the patient's concern into what is that medical issue, and then provide emotional validation or empathetic witnessing, as it's called here, and then either initiate treatment or refer to a specialist. So this might look like, the patient I had just mentioned telling me that because of severe vaginal dryness any penetrative intercourse feels like razor blades. So then, tell me more about it. What does that feel like? Have you tried to use, lubricants, or how did that go? And then sounds like you're experiencing vaginal dryness and decreased lubrication. That must be very difficult. Just providing the emotional support, because it can be a difficult topic and an emotional topic for patients to discuss, one that can cause a lot of distress. And then either to provide the treatment recommendations, those simple suggestions, or refer out to a specialist to do a more in-depth evaluation. And then moving on, and I'm going to talk a lot more about what's in these slides in the second half of the talk, but we do a core level assessment, which is essentially looking at sexual response, desire, arousal, orgasm, presence of pain, which can be caused by multiple different factors, and then the interpersonal relationship, so the sexual romantic relationship. And then to kind of understand the distress or the impact of that sexual problem. Because you could have one person who says, oh yeah, my husband and I, we don't have sex anymore, and I couldn't be happier. I hope never to have sex again, and I'm totally fine with that. And then you could have another person who has the exact same situation, but is causing a lot of distress to the individual, and they're upset. It's impacting the relationship. They feel a great loss and sense of grief over it. So really understanding the impact that the sexual problem has on the patient will be helpful to know what treatment is appropriate, what treatment is needed, and what that patient will want. And then the core level treatment, these are simple treatments that can be given in, the context of a follow-up medical visit, which is just education, information about non-hormonal moisturizers and lubricants, local hormone therapy. I'm going to talk about all this in detail, kind of behavioral changes that patients can make, such as foreplay, use of vibrators, non-penetrative sexual activity, and then assessing how the communication is. I'm going to pause right there. Are there any questions in the chat that we should talk about?
No, not yet.
Okay, perfect. All right. So, so that first part was really, how do we have that conversation? How do we assess sexual health? And then once the patient has told us, what can we do about it? So in this section, I'm going to talk about these different domains of sexual dysfunction in the context of a biopsychosocial model. How do we assess them? And then what are the treatments or the interventions that can be offered? And so I've sort of divided this into the biological or physical symptoms, sexual response symptoms, and then social or interpersonal psychosocial symptoms there too. So physical symptoms, one very common one is going to be the genitourinary syndrome of menopause, which I'm sure you're all well familiar with your patients. And so this is something that goes way beyond, vaginal dryness or decreased lubrication. Not only can it cause discomfort, pain, and friction with sex, it can cause bleeding. It can contribute to sexual response. And for women who are not sexually active, it can still cause significant symptoms such as irritation, burning, itching of the vulva or the vagina, dysuria, urinary frequency, urinary urgency. And then it also impacts the blood supply to the vagina, loss of rugal folds, vaginal stenosis can develop, narrowing and shortening. So really, understanding that the impact that the patients are experiencing is more than just vaginal dryness, which on the surface is easier to dismiss than kind of understanding all these different physical impacts that the patient's body is going through. So for some patients, a non-hormonal approach is going to be preferred. And in that case, we start with vaginal moisturizers and lubricants. And at least in my experience, among many of the patients that I see, they don't know about vaginal moisturizers. It's not a common knowledge that is just available to everybody. And so oftentimes patients have developed quite severe vaginal dryness before they even get to the point where they start using the vaginal moisturizers. So to be proactive about that, I start to talk about vaginal moisturizers even before a patient might develop those symptoms. And so these are products that when used on a regular basis can maintain the vaginal and vulvar moisture and the health of the tissue. And these are important regardless if a woman is sexually active or not. And then I always explain to the patients that vaginal lubricants are for a different purpose. They're to reduce the friction and the discomfort that comes with any genital touch or sexual activity. And that really the vaginal moisturizer needs to be used consistently, regardless if they're having sex or not. And really the studies have shown it needs to be used at least 3 times a week, if not 5 times a week, to have really good effects. So the different vaginal moisturizers that are out there, some of them are natural oils like coconut oil, or vitamin E or vitamin D capsules can be used. And then there's multiple products that can be purchased. And the ones that I've really started directing the patients towards are the ones that contain hyaluronic acid. So the 3 particular brands that are readily available here are Hyalogyne, Reverie, and one called Good Clean Love that has a product with a hyaluronic acid containing vaginal gel. And so really having that hyaluronic acid in the vaginal moisturizer provides a lot more moisturizing properties there. Then vaginal lubricants can be used as well. And I think it's important for patients to understand that there's differences between the vaginal lubricants. There's water-based and silicone-based products, and that they're different. And so essentially water-based ones are more readily available. They can be used with condoms. They can be used with silicone sex toys. They won't stain sheets, but they're not as long lasting. And so for women who have a lot of vaginal atrophy or dryness and decreased lubrication, they just may not be enough. So what I hear from my patients a lot is, oh yeah, I used a lubricant, but it didn't help. So then follow up that question with, what type of a lubricant did you use? Really, some patients do not know how to use a lubricant. And so just very factually explaining how it's used, apply it to your partner and to yourself, and then, when to use it. Sometimes that is necessary because, again, sexual health education in general does not necessarily address these issues for all people. The silicone-based lubricants are able to be used with condoms, but they cannot be used if they're using silicone sex toys. They do, however, stain the sheets, but the benefit is they are much more slippery and they are longer lasting. And also they can be used in water. And then oil-based lubricants are also sometimes used, but the important thing to counsel patients about in this regard is that they cannot be used with condoms because they can degrade the condom material and make them ineffective. And so I think making sure that as medical professionals, we have this basic information at hand so we can counsel patients appropriately about this. And I'm really sorry, I have to pause for just 1 second because my computer is about to run out of battery. And I'm just going to grab my charger real quick here.
Bueno, vamos a tomar un momento mientras la doctora resuelve su problema con la batería y retomamos la conferencia tan interesante que estamos llevando.
Okay, I am back. Can you hear me?
Yes.
Okay, I will start my video, and I'm so sorry about that.
Don't worry. Don't worry.
Okay, so the next thing I'm going to talk about here are these local hormones. So for many patients, there is going to be no contraindication or no concern about hormone replacement therapy. And so local hormones with vaginal estrogen are going to be a key component to treating genitourinary syndrome of menopause. And so I've just listed out multiple different vaginal estrogen products that are available. For some patients where you're aiming for a lower dose estrogen product, I'll usually go for a 4 microgram dose through a suppository called Imvexxy. For other patients, the S-trace or the Vagifem is appropriate. And then the S-string is a ring, and that can deliver a more long-acting, over 90-day delivery of vaginal estrogen. And so I think that for the majority of patients with non-hormone responsive cancers, if they are experiencing genitourinary syndrome of menopause, the early initiation of local hormones is going to be a key component of treatment. There's another form of sexual pain that is labeled insertional dyspareunia. And what that refers to is pain with the initial point of vaginal penetration. And this is a very specific symptom. And if a patient is experiencing it, they will know exactly what you're talking about. And there was a study that looked at the use of topical lidocaine. And this topical lidocaine was applied to the vestibule prior to sexual activity. And then after about 15 minutes, it was wiped off. Or I guess in this study, it was 3 minutes, it was wiped off. And then sexual activity commenced, and it reduced that symptom of dyspareunia significantly from 88% compared to 33% with the saline solution. So this is something that I will specifically ask patients if they have pain with sex. I will ask them, is the pain, does it have to do with friction, with decreased lubrication? Is it a deeper internal pain, or is it right at that initial point of penetration? And if that's the case, this topical lidocaine can be really effective. The other tool that can be used to help with the symptoms of the genitourinary syndrome of menopause is the use of vibrators. So that can increase blood flow and generally improve health too. So it can be useful for a medical professional to really just normalize use of these tools as something that could help a patient's sexual function. And so, if the goal is for someone to have improved sexual health, it can be helpful for the doctor to say vaginal, vibrators or use of vibration in the vagina can sometimes help with this. The next symptom I'm going to talk about is pelvic floor dysfunction. And so this is a really important symptom that can cause a lot of pain and a lot of distress to patients who experience it. And so what I see a lot more in those who are having sexual pain is an overactive pelvic floor, where they may have dyspareunia or vaginismus or vestibulodynia. And they can also, of course, develop issues related to urinary function or even constipation. And so referring to a pelvic floor physical therapist can be a key treatment for these patients who are experiencing sexual pain or sexual dysfunction that's related to the pelvic floor. And so for patients who are having pain with vaginal penetration during sexual activity, or for patients who have developed pain when they're having medical pelvic exams, referral and working with a pelvic floor physical therapist can be an extremely helpful intervention. And I've had so many patients who, have told me that they're physically unable to have sex, they're unable to have penetrative intercourse because of pain. And then after working with a pelvic floor physical therapist on the muscle dysfunction, they return a few months later and report back that they're able to have they're able to have sex without any pain. And that's such a huge impact to that person's quality of life. And they're very, very happy generally with working with the pelvic floor physical therapist. And so this is something that some centers even do preventatively or prophylactically after patients have surgery, or especially pelvic radiation, where they're expected to get maybe some stenosis or scarring and then resulting pelvic floor dysfunction, so that those therapies and those treatments can start before all of the damage has been done necessarily. And so they can start working with dilators and pelvic floor physical therapy. So some of the interventions that patients might experience when they meet with the pelvic floor physical therapist, some will be external exercises and external exams of the hip and the back and the abdominal area. And then if the patient is comfortable with it, the physical therapist will also do an internal pelvic exam to assess the pelvic floor muscles. And from there, they might do some simple stretches and, for example, yoga poses or breathing exercises. And they also may use vaginal dilators or trigger point wands to help the pelvic floor muscle dysfunction. And then there's other interventions that can also be done, for example, biofeedback for patients to be able to see what the result of their pelvic floor manipulations are. So vaginal dilators are a really helpful tool for patients who are either having pelvic floor dysfunction, vaginismus, or vaginal stenosis as a result of radiation or surgical changes. And so these are tools that come in graduated sizes. There's a bunch of different brands, different types, silicone, plastic, curved, they have handles on them. But we do know from many studies that have been reported that even if they're recommended to use it, many women discontinue the use of vaginal dilators because they don't feel sufficiently educated on how to use them, instructed on their use. So I've heard from, different places that patients might have been handed a dilator and told to use it, but they didn't know how often. They started using it, it hurt, they didn't know what to do, and so they stopped. And then, of course, what happens is when they come in for their next pelvic exam, they're having extreme pain, and then that can create some trauma when they're going through these painful exams. And so it can be helpful if the resources are available to work with a pelvic floor physical therapist together with the dilator so that the patient is confident that they're using it in the correct way, have that reinforcement when they're moving up to the larger sizes, and really feel confident in the use of the dilators. So another symptom that is termed vaginismus is a disorder where any form of vaginal penetration, whether it's a tampon, a digit, a dilator, a speculum, or having sexual intercourse, is painful or impossible. And this happens, and it can happen if patients have had pain previously, and then their body is anticipating more pain. And so then that develops this negative cycle of fear and anxiety. And then when they're in a situation where there is going to be vaginal penetration, they have involuntary tension and tensing up, anxiety, fear, and it creates this, feedback loop. And so the treatment for vaginismus is really multidisciplinary and multifactorial. So not only working with the vaginal dilators and the physical therapist, but sometimes using a counselor or a sex therapist to help with the fear and the anxiety components of it, to sort of understand how the patient can use the dilator. It's as much mental as it is physical. And so for those patients who are experiencing this particular concern, both a pelvic floor physical therapist and a counselor or a sex therapist are very important in overcoming this concern. And then another treatment of pelvic floor spasticity, of course, is injected Botox or botulism toxin. So another physical symptom that patients might experience are menopausal symptoms, and those are multifactorial. And certainly after gynecological cancer surgery, many patients might be experiencing premature menopause, whether it's induced by radiation or surgery. And there's a lot of data. I'm not going to go over all of this, but there's data out there about outcomes with the use of hormone replacement therapy for multiple different types of gynecological cancers. And I think it's important that hormone replacement therapy is offered to the appropriate patients for that. So, in my own sexual health clinic, I have encountered patients who have cervical cancer at a young age, and they were not on hormone replacement therapy. So certainly the overall symptoms and the sexual symptoms are going to be more significant. And really, there's no reason why that patient shouldn't have been on hormone replacement therapy. So it's important to remember that as a key component of addressing sexual function as well. And then a special scenario is the use of hormone replacement therapy in patients who are BRCA mutation carriers. And so if there has actually been a lot of data published on this. And so if the patient has intact breasts, so they have not undergone a prophylactic mastectomy, and they have no history of cancer, and they undergo oophorectomy, then hormone replacement therapy can be offered. And this particular reference has sort of said that if the patient has had prophylactic mastectomies, meaning they don't have their breast tissue and they go into premature menopause due to the oophorectomy, one should offer hormone replacement therapy at least until the age of natural menopause. And then if the patient has had a hormone positive breast cancer with a BRCA mutation, then hormone replacement therapy, of course, is contraindicated. So now I'm going to move on to the sexual response, which has to do with libido or desire, arousal, and orgasm. And so the ASCO guidelines that I referenced previously state that psychosocial or psychosexual counseling should be offered to women with cancer if they're having concerns about arousal, desire, or orgasm. And then clinicians may offer flibanserin to premenopausal women who are experiencing hypoactive sexual desire disorder. So the prevalence of hypoactive sexual desire disorder in the general population among premenopausal women is about 14%, but those who are under age 50 and who are surgically postmenopausal, that incidence rises much higher. And this is among patients who do not have a diagnosis of cancer. And so those rates are even higher when all of the other issues related to cancer diagnosis and treatment are thrown in there as well. So the first step that I usually use when approaching concerns about female sexual response, so desire, arousal, orgasm, is to really re-educate the patient about female sexual response. And so I think a lot of people may think that sexual response has to do with desire, and then arousal comes, and then orgasm, and then you're done. But for women, that's actually not the contemporary model of sexual response. And so the theory here is that for women, sexual response is more of a cycle, and it can be activated from a neutral state to an activated state through multiple different external or internal stimuli. And the key thing here is that desire or libido does not necessarily come first. And so for many women, it is actually arousal that will come first. And that is a normal way that the sexual response works. And it's actually how the majority of women experience it. So there can be a stimulus, which can be biological stimulus. So for example, cuddling, kissing, touching a partner, or a psychological stimulus like the desire for emotional intimacy. And that can lead to arousal. And then once the arousal has kicked in, then desire can come secondarily. And so many of my patients will report that they feel low libido. And when questioned a little further, what they're specifically referring to is lowering of the spontaneous desire, which is here in the middle. So the spontaneous sex drive, can feed into any of these aspects here. But the important thing to understand is that even if the spontaneous sex drive decreases, the woman can still experience responsive desire and still have a satisfying sex life. So by going over this information, I reframe it a little bit to say the goal is not necessarily to restore your spontaneous sex drive. The goal is more to activate your sexual response cycle, and that can be done through methods that help to improve arousal. And we'll talk a little bit more about that as well. So when it comes to desire, in addition to the psychological factors that I was talking about, it's also very biochemical as well. And there's many different factors, hormonal, serotonin, but also melanocortins that feed into this system of desire, arousal, and orgasm. And many of the medications or the drugs that we prescribe to patients with cancer can impact these issues negatively. And so different antidepressants can have different effects. In general, They're listed here, the relative impacts on sexual response. And then once you've reviewed the medication list to make sure that there's not medications that could be negatively impacting sexual response, then comes the general information or education on sexual response, communication, exercise, improves libido, diet and nutrition is important, and other things can play into there. If the general education and assessing the medication list has not helped, then there are actually 2 medications that are FDA approved in the US for low desire. Now, both of these are specifically approved for premenopausal women who have hypoactive sexual desire disorder. So that's a condition that by definition is not caused by a medical condition or a medication. So this is not strictly applicable to our patients who have a cancer diagnosis, but they are medications that can improve libido or desire. So the flibanserin acts on the serotonin receptor. And so these different receptors either will be activating to desire or suppress desire. And so flibanserin is this dual agent that enhances the activating pathway and blocks the inhibitory pathway. And it is a daily medication taken at bedtime. The warnings on this are hypotension and syncope, and to avoid alcohol. The second medication is called bremelanotide or Bilaci, and this is actually an injectable medication, which is used as needed. So the woman would inject herself with this medication 45 minutes before planned sexual activity on an as needed basis. And the main concerns here is that it can't be used in patients who have uncontrolled hypertension or cardiovascular disease, and it can also cause nausea. And so some people need to take ondansetron to counteract the nausea, at least in the beginning. And then briefly, for arousal or concerns about orgasm, the therapy of cognitive behavioral therapy can be shown to be effective. So if the resources are available, to refer to a sex therapist, that can be helpful for arousal and orgasm concerns. And then finally, body image and relationship concerns are really significant. If a person is not feeling confident in her body, that will impact her sexual function and sexual relationship. And body image, these women who are diagnosed with cancer can go through many different changes in their body image and how they relate to their body after experiencing cancer. And so the important thing here is to understand that this has nothing to do with the way somebody looks. It has the way that they perceive their body, the way that they think about their body, and the behaviors and emotions that are related to that. And so counseling can be a really important tool to address body image. And if body image is a concern, which it's a common concern, all the treatment for vaginal dryness and lubrication and things like that is not going to necessarily overcome what that issue is. And so that's why it's important to consider the entire biopsychosocial realm and ask about all these different areas. And the other thing that can be really helpful is relationship counseling, treating depression, anxiety, fatigue, insomnia. All of these other issues are important. So in order to give this is my last slide, in order to really give the patients the tools that they need, it's helpful to assemble a team within your community. And it doesn't all have to be at your hospital, but places where your patient could be seen or referred to. So someone who is specialized in sexual medicine, so that if they need a more in-depth evaluation, you have a point to refer the patient. Someone who is specialized in hormone treatment or hormonal replacement therapy, gynecological specialist, urologist, gynonc, pelvic floor physical therapist, somebody that is really skilled and trained and good that you can refer your patients to, a counselor that understands how to counsel patients who've gone through cancer regarding, relationship, mental health, body image. And then, at least in the US here, the sex therapist is a different training compared to the counselor. So there's additional training that somebody who's a sex therapist will have. So I have some patients I'll refer to a counselor, and then other patients I think would benefit more from meeting with a sex therapist. So those are the basic, in my opinion, referrals that you need to be able to provide this care. All right, well, those are my references. And then I'll leave, that's the pelvic wand used by the physical therapist as my question mark there at the end.
Well, thank you, Dr. Laila, for your nice conference. At the moment, we don't have any question on the chat, but I would like to make some questions. At what moment would you recommend to refer the patient to pelvic therapist after radiation therapy? Because the most common gynecological cancer we have here is cervical cancer. And many of our patients claims about a big afraid of restart their sexual intercourse. So sometimes we use the dilatators, the vaginal dilatators. Sometimes we use tampons because they cannot buy the other device, so we have to use tampons. But not always they accept to touch this part of their bodies or to talk about this topic during the time they go with us. So you said about refer them to the pelvic floor therapy. At what moment? Immediately after they finish the treatment, or when they have another sexual or psychological support, or how do you do that?
So, there's actually 3 different ways you could do it. The first one is you could have the patient meet with the pelvic therapist before their treatment. That way they know what to expect, they're comfortable, they understand that those changes are expected, and they know how they're going to be treated. So that's one option, is to make that referral even before the treatment is done. The second option, and it has to do with when the gynecological oncologist and the radiation doctor are releasing the patient to insert something in the vagina. And I think the comfort level with that differs. So some places and some institutions will refer the patients very early, like before the 4 to 6 week mark, because they wish to start the dilator therapy prior to the effects of the radiation kicking in. And then other institutions and other physicians prefer to have some period of not inserting anything in the vagina until a certain point and then refer after that. But either way, I think it would be valuable up front to counsel patients that this will be a recommended part of your treatment so that they expect it. They don't think anything's wrong with them having to go here. They just understand that's part of the rehabilitation. And then refer sort of at the time point when they will be using the vaginal dilator therapy, because it's not intuitive. It's hard to figure it out and it's hard to stick with it. So I think when patients work with the physical therapist, they get a much greater comfort level in using the dilators. So what we do is we usually refer them out about 4 weeks after the end of the radiation, and then they'll work with the physical therapist. Although that varies, that practice varies as well.
There's 2 questions in the chat, Heidi.
Yes. Dr. Florencia from Argentina would like to know what's your opinion about the CO2 laser and HIFU for improving lubrication in patients with cancer.
Yeah, so that's a great question. And I think that's a device, so like the CO2 fractionated laser therapy for the vagina, that has come out as a potential treatment option. I think currently more data is needed before it can be routinely recommended for patients after cancer. So they are coming out with more studies that are really, controlled properly, getting the laser, not getting the laser. And I'm waiting until there's data showing benefit in the specific patients. And so I am not recommending that for my patients at this time.
Okay, doctor. And what do you think about testosterone in patients with gynecological cancers?
So testosterone in terms of helping for libido or helping for lubrication?
Yes, helping for libido. And also for lubrication.
Yeah, so certainly that's a option. I personally tend to use more of the estrogen-based products, but there's also a product that's called prosterone or Intrarosa that has more androgen activity in it. And certainly patients who are having pain, testosterone topically on the vagina and vulva and vestibule can be a useful treatment there too. So I would say that it's a useful treatment option in selected situations.
Okay, you talk about flimbanserin treatment, and we have known one of our colleagues shared already a document about the controversies about this product because the troubles it had with its approval with the FDA and all the side effects it could have. What can you tell us about this?
So I prescribe that medication and I have not had any patients personally experience those issues. I think that there were a lot of controversies, but ultimately some of those have been resolved. And what I mean by that is that there was some signal about syncope and alcohol use and all that. So I do counsel my patients. I recommend that they don't drink alcohol when they're taking the flibanserin. So if they drink alcohol, just don't take the flibanserin that night, because it is a nightly medication. But in my experience, my patients have actually found that it helps sleep. So, this concern about sedation actually was a positive, that it helped them have more restful sleep and they did not feel sedated on it. So I do think that it is a medication that can be used. I think patients do need to be counseled about the potential side effects, of course, but they do not seem prohibitive to me. And my patients that have used it have had good experiences.
Okay, doctor, thank you. And finally, when do you recommend to do the sexual approach with our patients? After the treatment, before treatment, or just when they experience these first symptoms?
So I think it's important to address sexual function early and to prepare patients for what might happen so that when it does happen, they know that it is a common problem and that it can be treated. So just when you're talking about a side effect of a medication or a side effect of a surgery, that's when I would introduce the impact to sexual function. And so just like you're talking about all the other risks of a surgical procedure, I would introduce it at that point. So, it can have impact on sexual function, including, premature menopause, which can result in vaginal dryness, changes in libido. Some people develop pain. Those problems are treatable. And if you develop them, you can let me know and I can help you with the next step in treatment. So that, again, is normalizing that, establishing it as a consequence of cancer treatment so that they're not, honestly, some patients don't know why it's happening to their body because they've never been told. And so I think introducing it in a general way at the very beginning is helpful. Not that it has to be specifically asking the patients to share their information with you, but just saying this is something that can develop after treatment. And then assessing it when you're doing the subsequent visits. So, and I think the really important thing is not to wait until the patient brings it up, because only, there's a study done many years ago that showed that only 7% of patients will bring it up to their doctor. So everybody else is just suffering in silence. They're not going to bring it up themselves. So then to assess it on the follow-up visits and then continue to assess it. And just, to share some of my experience, I've had patients where I've asked them, do you have any concerns about sexual function? Do you have any dryness? And they'll tell me, no, I don't have any problems. And then they come in for their 3-month follow-up and they'll say, I know I said I didn't have any problems, but actually I have horrible problems. I haven't been able to have sex for 2 years. It's putting a lot of strain on me. I have a lot of pain. And they just were not ready to talk about it. But because I asked about it, that allowed them to bring it up at the next appointment.
Okay. And I have another more question. Do you have any scale or survey to apply to the patients after they finish the radiotherapy? Try to do a better approach, because it's not easy that patients, as you already said, could say all these things. So do you normally use any scale or recommend to use any scale or survey to evaluate this
Yeah,
comfort?
so right. So that's a great question. So there are a few surveys or scales that are out there. So one of them that I use when I do my sexual health clinic, but I do not use it for just my general medical oncology clinic, is called the Promise Brief Female Sexual Survey. So it's a maybe 20 question survey, and it asks about many different things. Another one is called the FSFI. So it's a questionnaire that patients can answer. But I think if you're looking for just a basic screening tool, the one that I listed in the presentation from the article by Sharon Bober and colleagues that has a checklist, something like that would be simpler, because the other forms are longer. And so, I mean, I think that just depends on how you wish to incorporate that. But the Promise and the FSFI are validated measures that are used for research, but they do take a little longer. And then the checklist is a shorter one that would be simpler to do in clinic.
Okay, Dr. Laila, thank you so much. We really appreciate your time and your very good management of this topic, that it's very important to take into account with our patients.
Thank you so much. It was my pleasure to be here.
Yes, we really love your conference. Thank you, Heidi, for your management of the conference. And Dr. Agrawal, I hope you will be with us in another circumstances too, and maybe we can bring you here to Colombia so you can be in person and for next week.
Yes, I would love that. Can't wait to come back.
Okay. Bueno, ¿alguien más tiene alguna otra pregunta para la doctora que quiera hacerle? Bueno, entonces les agradecemos a todos por su asistencia.
Yo tengo una pregunta, una
Sí.
pregunta.
Indira,
No sé, pues no
doctora.
me queda claro si la doctora ya lo mencionó, porque hubo un momento en que me tocó desconectarme, pero hay pacientes que le preguntan a uno, sobre todo las pacientes con cáncer de cervix, cuando uno les manda los dilatadores vaginales después de la radioterapia, y ellas, pues la mayoría se mandan por 6 meses para evitar que se cierre la vagina, pero ellas le preguntan a uno, doctora, y si yo no tengo pareja, yo me puedo seguir introduciendo en la vagina el aparato o cualquier otro juguete sexual, pero me da miedo que eso me vaya a dar otro tipo de cáncer. ¿La doctora ha escuchado, sabe algo de eso?
Dr. Agrawal, did you hear what the translator said? Dr. Agrawal?
Desconecto.
No, did you hear, can you hear us? No, no se está escuchando.
Creo que está desconectada.
Doctor, can you hear us?
Yes, I can.
Ah, es que está en el... Did you hear what the translator said to you?
No, I only heard the Spanish, but I didn't understand it all.
Okay. ¿Alguien nos están escuchando lo que estoy hablando con la doctora?
Sí, señora.
Ah, bueno. Okay, so Indira asked you, Dr. Indira is from Cali, and she's asking you if what I understand what she said is that is there any the patients sometimes ask if those dilators and the sex toys.
No, sexual toys.
Sex toys can cause cancer.
They are afraid.
They have these issues. They are afraid that it can cause cancer.
Any kind of cancer by use these toys.
No.
Have you heard?
I don't think there's any evidence
about
or
that?
any information about that. I mean, does that have to do with like shame regarding use of this, or do you know what the concern is?
Indira, que cuál,
Ex-
si es por pena o cuál es
No,
el
o sea, los,
problema de las pacientes.
no, que si por ejemplo las pacientes tienen miedo de seguir usando para que les cierre la vagina, cualquier otro dispositivo que no, cuando no tienen pareja, cualquier otro dispositivo para que no haya oclusión de la vagina. Entonces, ellas preguntan a veces que si hay algún tipo de juguete especial que puedan usar y que no las vaya a predisponer a un cáncer, pues por las sustancias de las cuales han hecho estos productos o de los componentes que están hechos estos
Patients are
productos.
concerned about what these products are made of, that maybe they can cause cancer. They have told her, and then they are concerned about.
Los productos, o sea, el componente
Did you
que están
have
hechos los
any-
juguetes.
Did the patients ask you about that?
Yeah, no, I haven't actually heard that from patients, that concern. But I mean, certainly, sex toys are widely available. I mean, you can buy them on Amazon, you can buy them at Walmart, the drugstore, so I think just knowing what the components are, making sure that they're purchasing from a well-known company. But, the silicone, battery operated, all of those things do not cause cancer, and use of a vibrator, use of a stimulator, use of a dildo, vaginal dilator does not cause cancer.
Okay.
Thank you.
Okay, thank you, doctor. Really, we enjoyed very much your talk. Bueno, si alguien más tiene alguna otra pregunta, y si no, nos despedimos. Okay, doctor, really, we enjoyed having you today. Have a nice night, sleep well.
Thank you so much. It was such a pleasure to be here. Bye.
Bueno, hasta luego todos. Muchas
Thank
gracias
you.
por asistir. Muchas gracias, Katie. Gracias.
Hasta luego. Gracias, doctora. Buenas noches.
Chao.
All right. Thank you. Bye.